So I just want to take a few moments to just introduce myself. My name is Shayla Knighton Black, and I'm a capacity building specialist for the Latino Commission on AIDS, specifically the Hands United program, which is our capacity building portion of LACOA. And I'm so happy to see everyone today. I'm so happy to have this discussion today. So before I begin, I wanted to mention a few housekeeping things. Um, I don't think you all are able to unmute yourselves, but at the end, we will be having a question and answer portion. And if you have a question, you can raise your hand and we'll try to get through as many as we can. If you can raise your hand, you can either put your question in the chat box, or we can update you so that you can upgrade you so that you can speak in through your mic. Also, if you have any questions throughout at all, just if you're having issues with anything on the Zoom, feel free to also message us. We'll be monitoring it as well. So today, I'm so excited for today because I'm joined by two amazing women who are near and dear to my heart. I love them both, and they both know this. I'm going to start by first introducing Miss Kierra Del Aldanola, one of my good friends. She serves as the chair for the Black Treatment Advocates Network, BTAN of Big Bend, Tallahassee. BTAN is a network of HIV/AIDS stakeholders, including providers, community members and leaders, educators, and people living with HIV that work to mobilize Black communities across the country to confront HIV. She also serves as the statewide community mobilization coordinator for the Florida Department of Health. And she serves as the lead for the business response to AIDS and the faith response to AIDS. Most of us probably know it as Berta and Ferta. She's also a graduate of the Florida A&M University, my alma mater as well. Go girl. And where she obtained her Master of Public Health degree in 2017 from the Institute of Public Health. She interned as an epidemiologist on the Medical Monitoring Project for Florida Department of Health and for the HIV/AIDS surveillance section. And she has conducted research on the effectiveness of sexual health workshops on college campuses. So I'd like to welcome Ms. Kierra. Thank you for joining me again.
Thank you, Shayla.
And now a person that probably helped mold both of us. She is like a real titan in public health and in HIV prevention as a whole. And that's Miss Leisha McKinley Beach. And I know a lot of you on here know her. She is amazing. I'm sorry for sorry, Leisha. Alicia is the founder and CEO of Kush Health Impact and Leisha.org. She serves as a consultant who provides training and community engagement on HIV and other issues affecting the Black community, especially Black women. She also provides technical assistance on HIV program design and implementation for Black population, capacity building assistance to health departments and community-based organizations, particularly on issues for women and communities of color, and mobilization of PrEP scale-up in the Black community. As the HIV prevention program manager at the Fulton County Department of Health and Wellness in Georgia, Ms. Leisha has played an important role in catalyzing and supporting the launch of the South's first public sector PrEP clinic, specifically designed for to spur PrEP access in the Black community. Ms. McKinley Beach received her undergraduate bachelor degree from University of Florida.
Go
and
Gators.
Go Gators. And her master's degree in health science from University of West Florida. So I want to say again, ladies, thank you so, so much for joining me today. I'm so happy to have you both here.
Thank you. Thank you for the invite, Shayla.
You're welcome.
Thank you.
No problem. So today I wanted to take a little time. I didn't feel this is the best time to have this conversation. We're rounding out Black History Month. It's coming to a close. Leading into March, which March 10th, I believe, is National Women and Girls HIV Awareness Day. So of course we got to talk about women and bring this to the forefront and kind of make it a focus for moving forward. So I want to provide a little background for context. And I know a lot of us on here already work in this field, but just in case there's someone who didn't, in 2018, women made up 19% of the new HIV diagnosis in the United States. Of that 19%, 57% were Black women. And we've seen a few increase. We've seen a good increase, decrease in new HIV infections in Black women between the times of 2010 and 2017. But overall, there's still a lack of Black women engaging in a lot of prevention methods, especially PrEP and nPEP. So, as a little bit of refresher course, a little bit of refresher about what PrEP is. PrEP or pre-exposure prophylaxis is a medication that, if taken as prescribed, can reduces your chance of acquiring HIV. So that leads us basically to our first question, ladies. So I mentioned we're seeing Black women account for the smallest percentage of PrEP and nPEP users to date, but they could benefit the most. What factors do you think are at play in the relatively low uptake of PrEP among Black women? Either one of you, please.
Um, Shayla, that one question could be this whole discussion,
Yes.
quite honestly. When we look at the slow uptake of PrEP, we have to start with the some of the foundational issues for that, and it does not start with Black women. It
Mhm.
starts with both the structure for our healthcare system. It starts with some of the bias among our medical providers and those who do know about PrEP, even having that conversation with women about PrEP. And those issues are key, and those are the things that are gonna have to be addressed. I was very fortunate to be a part of a project that focused on uh, family planning clinics. And so when you hear that name, family planning,
Mhm.
one may think of women first, right? So this is a PrEP demonstration project in family planning clinics. Women surely will be the focus. But what they discovered was when men came into the clinic, the clinicians automatically had a conversation with men about PrEP, but did not do the same for women. And that was their primary audience. And this is a national provider, so they have clinics everywhere. And you saw similar patterns across the country. And so that speaks to the medical bias in terms of who needs PrEP and who doesn't need PrEP. And if you aren't informed and educated and aware that PrEP is for women, we can go throughout our entire medical healthcare process and nobody mentions PrEP about us.
That's very true.
I agree. I totally agree. And in addition to that, the lack of information. When I used to work directly with clients, every client I would talk to about PrEP, and some people would say, "Oh, I didn't even know this was for me. I thought it was already for people living with HIV." And so it's just the lack of education, and also the medical mistrust. Well, if you have something like this to prevent HIV, I'm sure you all have the cure, and different things like that. And then dismantling the stigma around PrEP and different things like that. So everything Leisha said, in addition to those few things as well, I think that's some of the biggest issues. And like Leisha said, that one question alone can carry this whole conversation. So
It's interesting you brought up medical mistrust because that was actually the next question. We've seen so many different examples of medical mistrust throughout history, to people of color, to women. One that I recently learned about that I was just completely unaware of was what happened in Puerto Rico with birth control and how it was marketed. I can't remember the name of the medication, but it was marketed as just postponing having another child. You already have your family, like you can wait, but it was actually sterilizing these women and they didn't even know. And so my next question, I'm going to direct it to you, Kierra, since you mentioned medical mistrust, is what are some ways that we as providers can kind of ease that? What can we do to let the community as a whole know that this is something that's going to help us, not to cause a detriment to us?
I think one of the things is when we have the information, let's just use COVID. We have these webinars amongst our colleagues, but how are we getting this information to the community and putting it into words that they understand? Everybody's not going to understand medical jargon that we throw at each other, right? So yeah, we know about PrEP. We could talk about it all day, but how are we relating the information to the community? How are we getting that to the community? And once they pose these questions about, well, I don't believe in it or I don't trust it, how are we dismantling that stigma? How are we saying, hey, here's the numbers for you to understand, and this is the data, to show you that this is actually effective. And I think that's one of the biggest things is that sometimes it stops at us and we don't really convey the message correctly. And so that leads to people Googling stuff and, oh, well, I saw this with PrEP, somebody lost a leg or something, and the internet is quick, so we have to compete pretty much against false information that's out there and so forth and so on. So we have to learn how to get the information and relay it to the community in the way that they understand, they have the tools and the resources, because like I said, we can do PrEP seminars and webinars all day, but are we really reaching the people that we need to reach? And when we do get to those folks, how are we giving them the correct information, making them comfortable enough to take this medication, and how do we give it to them in a way that it clicks to them, And I always used to tell women who I would refer to PrEP is that just take this right along with taking your birth control pill. If you take your birth control pill in the morning at 9 a.m., go ahead and make sure you take your PrEP pill, or, so forth and so on. So I try to relate it to like everyday messaging or everyday activities. And, anytime they have a question about side effects, be honest. Hey, this is what I know from the data. You may have a little headache or a little nausea, but, those are rare in some cases. Be honest, because if you don't, and then something happens to the patient, it's like, well, you didn't tell me this. You told me everything was going to be fine. Now, she, Carla has her friends don't get on it, and then now they told 10 of their friends to don't, not get on it, and it just, just spirals from there. So I know I kind of went on the tangent. I'm going to let Leisha speak on it some, but those are some things that I think we need to do. We need to make sure that the message is getting to the people that it needs to get to, and we're being honest with our clients.
Yeah, no, you're on a roll, and you are so correct in that regard. I am going to ask the participants if you will use your chat feature and describe for us with one word, what thoughts come to mind or what feelings come to mind when you hear that Black women aren't even being told about PrEP from their healthcare provider. So share with us in the chat feature one word that describes your thoughts or feelings about that. But I want to go back to something that that Kierra said, and it's speaking to the words that I see coming in, this shame and disappointment, injustice, ignorance, bias, sadness. All of that has been a part of our legacy in healthcare, period. Right? And so, Shayla, you started talking about what you the story about birth control in Puerto Rico, and these same words that are coming up around racism and malpractice and fear and social justice that happened with that with that model of mistrust is the same thing that happened we saw in southern states, specifically Mississippi, with the model of the Mississippi appendectomy, right? And so what happened during that era was when Black women would go to the hospital, regardless of what they went for, they were provided a hysterectomy. And this was a way for Mississippi to control the Black population in their state. And when we think about one of our great civil rights leaders, Fannie Lou Hamer, who wasn't exempt from this process as well. So, Fannie Lou Hamer goes into the hospital for, pain that she's having, and they perform a hysterectomy on her with no consent. Right. And so when we talk about medical mistrust, it's so far beyond just the Tuskegee study. And later on we'll talk about, why we have to use that framework, acknowledge it, and be able to move past that, because there's so much that's happened to us in this country that is bigger and greater than what happened in Tuskegee. And so when we fast forward to what we're talking about now in terms of prep, there is still this model of Black women not being prioritized or centered, right? There are some providers who are informed about PrEP, and they make a decision not to have these conversations with Black women. Um, Even when we look within both our public health structure, everybody is not talking about PrEP for Black women. Many of our conversations are around PrEP for men. And are those necessary? Absolutely. We're not saying stop that. We're saying scale up to include Black women as a part of those conversations. And it's so unfortunate. I was thinking about Kierra, something else that you had said just about the education. And I remember doing a training or something in Pensacola a few years ago, and we were asking folks about the commercials that were on promoting PrEP. One of the women said, I didn't realize that commercial was educating people like me about PrEP. She said, first off, the commercial started with, I'm on the pill. I'm a woman who has gone through menopause, right? So that's the moment for me to get up and, and go get a snack while, the commercial is on, because that has nothing to do with me. And then when she saw the images, that reconfirmed that truly has nothing to do with me, because none of those images look like me. And so we have to be mindful of the significance and the importance of messaging when we are talking about PrEP for women. You can't just take, a commercial and then, slap a pink background and say, oh, that's for women. It needs to look like, feel like, be designed by women for women, so that women know that, yes, this too is a prevention strategy for you.
I agree. And in addition to that, Leisha, I think I know the commercial you're referencing, because there have been a few, and it's like, where am I? Now there is one with a Black woman in there. She kind of looks like me, but was like the only commercial. And so I definitely had these discussions with other colleagues, and even when it comes to the research, and hopefully this is not the next question, because I don't want to get too deep if we're going to talk about it a little later, but even when it comes to the research, when it comes to PrEP, where are the Black women, And so I'm going to hold it there, because I feel like, Shayla, that might be a question down the line, but that's another thing. Like, we're excluded from the research as well. Like, are you really recruiting us? Are you giving your best effort to get us in these studies? Because we're all left out.
Mm-hmm. I am going to ask something that has to do with that in a little bit. So I will put a pin in that too. The next thing we want to talk about, we kind of mentioned it a little bit, was the social determinants of health and how that affects how women engage in PrEP, and also just the overall health of Black women, period. So can both of you speak a little bit on like the social determinants and how that can play a role in women engaging or accessing PrEP?
Yeah. So if for me, I would just say from experience of what I used to see is, sometimes we lose women. I would just say in general, we lose people when it comes to PrEP prescriptions due to these social determinants of health. And that could include, unstable housing, transportation issues, money issues, people who, don't have insurance but don't qualify for government insurance like Medicaid, Medicare, different things like that. So it's a whole slew of things that comes into play. And, when you're worried about how I'm going to I'm either going to get my child to school on the bus and only have one bus pass for the day versus our PrEP refill, what am I going to do? I'm going to get my child to school, get my child something to eat, and I'll worry about this prescription or fill up to another day. And I can say that as just a person who has access to the information, who has, access to be able to have good health care. And I'll use me for an example when it comes to blood work. My doctor always tells me, Kierra, you're missing your lab work. I want you to go to Quest to get your lab work. But my life is so busy, and 6 months later, I still haven't got this lab work, because there's other things going on in the background in my life. And I'm like, if you don't do my lab work in office, I'm telling you, I'm not going to be able to do it right when you want me to do it. So I can imagine people who don't even have the resources that I have to worry about a PrEP prescription or a refill or coming back to follow up with lab work and different things like that. So it's so much that comes into play. And even for people without stable housing, they're moving from house to house or from couch to couch or from shelter to shelter. And it's like, I'm not worried about a prescription. Yes, I have my prescription, or I'm on my last 3 pills, but right now I need to worry about where I'm going to lay my head at. And we have to address those things as well.
And Shayla, I don't know if you have a question around stigma, but okay, so I'm just kind of following some of
the next question, so you could go ahead.
Okay, all right. So I'm gonna hold my comments on stigma. I just see what's happening in the chat, and I wanted us to be able to address it. But I want to add to what Kierra is saying around social determinants of health. And for years, I have said the part of the reason why we are so challenged with getting to the end of the epidemic before that became, a buzz phrase for us. But our challenge has been we start focusing on the HIV epidemic with a test result. And for us, there are a whole host of issues that got us to that test result. And if we don't focus on those things first, we're still going to be pouring money into HIV screenings, care, and treatment because we're not dealing what keeps putting more folks into the system. And I think that that's important to uplift because even when we factor in Black women and white women both having health insurance, having the same level of education, we still see poor outcomes for Black women than we do for white women. Some of this is medical bias in terms of the treatment that is offered, the medications that are provided, the medical plan that is given to women of color compared to other women. And so that is what it is. But the other part is I can talk to you all day long about reducing risk, about choosing PrEP as a prevention option for you. But if you can't afford the copay, or you can't afford the transportation to, Kierra talked about the time to the lab. What if I can't afford the transportation to and from the lab? Or what if I can't afford the time off of my hourly job versus those who have a salary job. And so we have to look at all of those barriers as well. And that's if I'm in a medical home that's even teaching me or helping me learn how to assess my risk, how to determine if prep is something that's for me, or helping me to determine that it may not be something that I need now, but it could be something I need in the future. And I know that based on my ability to assess my own risk. And so a lot of those things aren't happening. And it's very, very challenging to be talking to someone about their health and prevention strategies when I'm really not sure if I'm still going to have a roof over my head by the end of the month, right? And so like that's where my focus is. And once I get this housing thing situated, then I can focus on what you are talking about. And so until we understand we got to treat the whole person, we're going to keep finding ourselves having these same discussions.
Thank you so much, Alicia and Kiara. Those are, all great points that you all made. In my experience working with Black women or trying to engage Black women, what I have found, and I could speak from, my experience with women that I know personally, friends and family and cousins and everyone because I'm always talking about prep. I'm always, hey, are y'all taking prep? Oh, you want to, have you thought about it? Or, people are blown away when they find out about nPEP. Like you would have told them that I just invented a light bulb. Like they're like, what? You could take something to
Mhm.
stop you from getting HIV in case you were. I was like, yes, it's really out there. It's a thing. Like you should use it. My what I have found is there's a little bit of a lack of perceived risk. Some women feel that if they're not, having sex with someone who is, as I've heard, I'm not sleeping with somebody who's gay, or I'm not doing this. Oh, my boyfriend, my man, not gay, my this and that. I'm like, that's not the only way. That's not the only, gay men aren't the only people that are living with HIV. There's a lot of straight men living with HIV. There are a lot of women living with HIV. And so that lack of perceived risk sometimes, and it stemmed from, as we talked about, as our next question we're coming up to, is stigma, the effects of stigma on people's ideas about healthcare in general, but specifically HIV, especially in the Black community. So I wanted to ask both of you, what are some things or what are some ways that we can try to ease that stigma and try to engage women in understanding that there's nothing wrong with taking prep. It's just like adding another thing into your life that will, help you stay healthy. We're all talking about keto diet. I'm doing keto diet. We're always adding new things into our lives to make us better or to elongate our lives. So what's wrong with adding prep to it? So there's that stigma around it. What can we do to ease that?
Well, first off, we gotta own our part of the stigma, and the our is our HIV workforce. And I'm gonna make this statement, and if you think this statement is correct, please just put yes in the chat feature so I know, that as the elder on the group, that I'm not out here by myself. We put a face on what HIV was, and we put behavior on what HIV was, and it gave a lot of people an out, especially women like me. I'm a married woman. I'm a middle-aged woman. I don't care how I try to change my look, that church girl still come through. So I'm the church girl woman. Nobody is talking to me about prep. Nobody. Because you have made some assumptions about me based on the appearance that I provide to you. Right? And so that too then adds to this stigma. So we got to own what we did in our HIV workforce of saying, this risk and this image and these young people and all of that. And now that I'm not a part of that, oh, let me do something to help those women, right? Let me, let me contribute to doing the education through my sorority group, because we like to help people in need. When the reality is all the women at the sorority meeting, not meeting, at the sorority meeting, they need to be hearing this so that they learn how to assess their own risk. And I have seen this even personally when I had to ask my provider for an HIV test. And then my provider then says, I'm sorry, I thought you were married. Right? So he has made an assumption there is no need for me to have any sexual health screenings, as if my marital status has provided this safety net for me. And so those types of things, also add to the stigma. What I have found in terms of PrEP, and this has been both sad and an eye opener for me. Right now, there have been several times our federal partners, state and local partners. I'm actually on a panel for the Biomedical Prevention Summit, and we're still having a hard time finding a Black woman who has chosen PrEP as her prevention option to speak on the panel. And so I'm gonna put my email in the chat box when I finish this sermon. And then you can email me your tithes and offerings and a connection to a woman who wants to, who would be willing to participate on the panel. But what I have heard from some women have been, if I participate, then people who may not have known that, and I'm not talking about a partner they randomly, picked up. I'm talking about my husband, my longtime, life partner, whatever. People may not know his status. And by me talking about it publicly, I'm disclosing his status. So no, I can't do anything about PrEP. I've heard from other women who said that women like me, that they went into their provider's office and then they hear the comments from the younger staff there about how old she was and why she needed PrEP. And that's a shame, as old as she is, that she need to be on PrEP. So again, that stigma, even around older women who we may be teaching them about how to assess if PrEP is the best prevention option for them, and then they go and do what we have told them to do, and they get to these medical homes, and then they got to hear that type of comment. And so, hearing, this from a woman who said, we've known his status for years, and I haven't gotten HIV, to date. So I'm not gonna continue on PrEP. I don't need to go through that type of drama. We just gonna pray that I can still remain negative. Those were her exact words. And so, and I keep raising this because when we talk about stigma, we oftentimes start talking about internal stigma. And I'm certain that Kierra is going to talk about that. But we got to talk about the stigma that comes from this whole HIV workforce. And instead of us pointing the fingers outside, we got to look inside at what we're doing. And we are in a great place that we can change that, to be able to help create an environment for women to want to choose this as a prevention option and be comfortable talking about it.
I agree, and just to add my 2 cents, because Leisha, you are everything. That was But just to add about the providers, even I personally switched providers because one, she did not know the field that I worked in. And, you know, when I went to go ask for STI screening, she was like, didn't you just get married? I'm like, what does that have to do with anything? Like, you don't know my life. You don't know my husband's life. Before I was married, I was getting tested. After, just because I'm a married woman does not mean that's going to stop. You don't know what I'm doing behind closed doors. You don't know what my husband is doing behind closed doors. And she will always miss things. And then when I, you know, got on the conversation about prep and, you know, all of this stuff, she just was like, whoa, what are you doing? What are you talking about? And then I disclosed that, you know, I work, you know, in HIV. And this is why I'm coming to you, because you know, some people may not be able to advocate for themselves to say, hey, I want to, you know, STI screening, or I want a PrEP prescription, and you're not even offering it, you know, that's somebody that we missed, you know. And I kind of educated her about it, but, you know, I had to end up leaving her because it was too many inconsistencies for me. And so I was just like, you know, with the education, provider, you empower yourself as well, because it's like if you keep that bias, and just because I'm married, or you know, whatever the case may be, that doesn't mean anything, or I'm an older woman, that doesn't mean anything. You could be possibly missing somebody who is at risk. And like you said, Shayla, that's a huge one with low perceived risk. I remember I had a client back in the day, and like I say, I talk to every client about PrEP, whether you feel like you may need it or not. And she was a married woman, and she was like, oh, you know, I'm going through my whole spiel, and you know, and she was like, oh, well, I don't think that's for me, because you know, I have sex anally. And I'm like, you know, that's just, you know, I had to educate her as the ways of transmission of HIV and, you know, different things like that. And so it's just like people, they really don't know, or they don't think they're at risk for acquiring HIV. And they don't realize that, you know, PrEP it's just another tool in your toolbox, just like your birth control or medication for diabetes, you know, your asthma pump. It's the same thing. It's a tool in your toolbox to, you know, to make sure that you have something to say that if this, like you say, exposure, if something was to happen, or I'm just preparing myself just in case, or just like your diabetes medicine, I don't want to have a flare up, so let me make sure I take my medication just in case. And so I think that's one of the biggest issues. And I say that because, like I said, even just me being somebody that's in this field and a provider, like Leisha, looking at me in shock when I asked for a 4-panel STI screening, right. Need that for? Do you just get? I was a newlywed, but she was like, "Do you just get married?" I'm like, "What does that have to do with anything?" But okay. So, yeah, definitely low perceived risk, and another thing that I hear, and I'm going to get off this soapbox, but is I saw in the chat, a lot of people think this is just for gay men, and it's not. It's truly not. And I come into that sometimes. Well, I thought it was just for gay people, or you know, well, I'm not gay, so I don't need to be on it. And it's like, no, boo, that's not the case. And so definitely low perceived risk. I see that a lot, and I think that's also a huge issue that we have to address. But that comes back with the education and making sure you're not skipping clients, making sure you're not, you know, putting your bias on them. Oh, well, she said she married, I'm not going to talk to her about PrEP. Or she has one sexual partner, I'm not going to talk to her. Like, no, you need to talk to everyone, because you don't know. Somebody can say they have one partner, but may have forgot, you know, they might have had a drunk night last night and had 3 partners. You get what I'm saying? So I always make it a deal, especially when I used to teach the 500, 501 classes. Talk to every client, because you don't know. And even if they say at that time, well, right now it may not be for me, a week from now, it may be for them. Tomorrow, when they go home and think about it, it may be for them. So I want people to just make sure that they're reaching out to everyone and letting clients understand a small risk, big risk. A risk is a risk, you know, and I think that's an issue too. It's like, oh, we only have one partner. You still having sex. Right. You're still having sex. And so it's like, well, I'm not having 6 partners. You're having sex. So, but yeah.
And I think, Kierra, you said something that I will put in one of the takeaways, and that is, our language does matter. And when we start talking about high risk versus low risk, again, that gives some folks an out. But risk is risk, and if you are sexually active, period, this is a conversation that needs to be had with you, period.
Mhm.
And so again, that's something we can change today. And so we stop giving people this false sense of security, that, oh, well, they not high risk. Well, risk is risk, and so, and you don't know my story, but the more that we begin to talk and you begin to educate me, I may see, wow, this is something that, that I may, truly need. And then I saw in the chat feature that you also mentioned this perception that prep was for white gay men. I will tell you that when I first saw the very first print poster related to prep, my first comments, yes, as the church lady, was, oh hell, here we go again, right? Because in 1981, when we got the first printed material from the MMWR talking about HIV, we are coming up on the 40-year anniversary in 4 months from that very first publication. And they talked about 5 white gay men. And that whole time that there were cases in Black communities, among Black gay men, among Black women, among Black heterosexual men, there were cases that were happening even then. We have spent 40 years still trying to correct that huge mistake and letting Black communities know, I know we let our guard down saying, finally, this one thing that don't involve Black people, this one thing ain't got nothing to do with us. We sorry it's in other communities, but it's something we're not leading. There were cases that were happening all along. And then you fast forward to 2012, and there's this discussion, and approval, to use this medication for PrEP. And the first things that I see in the print materials and the radio commercials, they are of white gay men. And so we have just repeated history, now chasing that myth, that erroneous information, to let Black people and Black women know, this is for us as well. And so at some point we are supposed to learn from our history and not keep making the same mistakes over and over again.
And
It's
I'll add
interesting.
to that, Leisha, even with COVID, right? When
I was
COVID came,
about to say that.
it was things coming out saying, oh, it doesn't affect Black people. So we were out here just lollygagging around. And now look, we're the people that are dying at the highest rate from this virus. It was the same way with COVID. Oh, Black people can't get COVID. Now look.
I was actually just about to say that it's the same idea came along with COVID. And also, I don't know if I was talking about this with a friend of mine. I don't know if you remember 2 years ago when we had the vaping injury. There were a lot of young African American young adults and teenagers that were dealing with that vaping injury, but it wasn't really talked about as much either. But then COVID came along and just kind of overshadowed all of that. So I did want to just take one moment to let the participants know that there will be, we have a poll um, that's coming up. And the poll question is, what do you all think is the most pressing issue for PrEP amongst Black women? And it should be launched in just a few, it should be up now. So if you all could just pick your option for what are the most pressing concerns when it comes to PrEP and nPEP amongst Black women. So, ladies, so we've talked so much about stigma. We talked a lot about all of these social determinants. We talked about why women don't engage in prep. So now we want to focus for the last part of our conversation. We want to talk about what we can do to lessen those barriers and increase access to prep and nPEP. So, what are some things that we as providers can do to just make things better for Black women in regard to prep?
Well, one of the things that I would recommend, Shayla, and you mentioned this earlier as you were talking about PEP, um, is ensuring that our community is aware and informed about what that is, but more so ensuring the medical community. And the reason I mentioned that, last year, we had an incident in Metro Atlanta where where a woman needed PEP, and she went to the the county hospital, the emergency department, explained what had happened to her, and they told her they didn't handle that. That was something that only the health department did. And this is Friday evening. The health department is closed, and they don't open again until Monday, right? And so time is not on our side, in terms of PEP and making sure that she was able to start within 72 hours. We go back to educate the hospital, and they were like, "Oh no, I mean that ain't something that we gonna do. That's just something we refer over to the health department." And even after understanding the time period connected to PEP, they were still adamant. We don't want to get in that business, if we can't refer them to the health department, if you can provide us with a list of where they can go, that would be great. And so, even if we educate and there isn't access, and that's the other thing, ensuring that there is access for women, that, again, we got these tools, but we're not benefiting from them. And so I think, that will be key. There was also something that came up in the chat about injectable prep, which will probably be approved maybe later this year. Um, and, what are our thoughts and feelings about women being able to access injectable prep, especially around all of the mistrust? Um, my thing is, I see the education for Black women clients came to the top of our poll. But I would also challenge us to think about that is true, so that women are the empowered client when they go in, that they know about prep. But I also think that if I go in and I know about it, my medical provider needs to know just as much as me, if not more. And so we have to do a better job of ensuring that our medical staff, including OBGYNs, if there was one group of specialists that I would say have to rise to the top for women, that's OBGYNs. And so some of these great states that I see represented on this webinar, I saw Florida, Maryland, Missouri, Texas, Delaware, Georgia. I think I even saw somebody from India that's a part of the webinar today. um Hosting those convenings for OBGYNs on educating about prep and nPEP for women will be a great start for us. But I do want to go back to the injectable and this question around the mistrust. Our mistrust is what it is, and mistrust means we may not have been a part of it, but it's something that's been passed down from generation to generation. and there's a culture of storytelling. We have heard of these horrific things that have happened, but some of us, as Kierra and I both gave examples of things that happened to us in medical appointments, we now have our own narrative around distrust, right? So I distrusted because it happened to me. But what we have to do is to move our community from the being stuck with us just being aware of medical mistrust and then our own trauma behind incidents that have occurred that create distrust, to I'm not going to help them kill me off by not using prevention strategies. I'm not going to help them kill me off by not taking a vaccine, because I need to still be here, to be showing up at these county commissioner meetings, to be showing up at city council, talking about the injustice that's occurring, around healthcare, education, roads, pavements, all of the above. And so looking at it from that lens, is how we have to move our community. And a part of that is having people who are gone through these experiences share their stories. The art of storytelling in our community is so crucial. There are things that people will say now, that they believe to be true. Why? Because Shayla said it. Shayla said, the chicken noodle soup really does work as a comfort food when you got the cold. Now, it may not be a lick of research behind it, but I trust Shayla, right? And so if Shayla is sharing that information, then it must be true. And so some of us have to realize the trust, and the respect that people have given us, just like the ladies on this call, on this webinar, talking about, oh, well, here comes Leisha. Y'all know I'm always just Leisha. That's who I am, but I am a storyteller. And so I always got to make sure what I'm saying is accurate and true, because somebody may leave here today and go ask their gynecologist, be like, I just want to know why you ain't talked to me about PrEP, because Leisha said, you were supposed to talk to me about PrEP. And yeah, I'm going to stand by that. They should be knowledgeable enough to talk to you about it. But don't lose the art of storytelling. Don't lose that not only does the message matters, but the messenger truly does matter. If Kierra tells me that something is happening right now in the Florida Department of Health, I'm gonna believe her. Why? Because I trust the messenger. And so that becomes a part of our responsibility as well.
You just gave us a word.
Agree. 100%. She summed it up perfectly. But I will definitely just emphasize the messenger definitely matters. And, not to open up a can of worms, but that just made me think about some of the positions and roles that, certain people may have. We're trying to affect a community, you need to have people in places that look like this community, because you can tell me all day, oh, you need to get on PrEP, but if I really don't understand PrEP and my provider is an old white man and you're telling me this, and then I know all this history behind me, I'm not going to believe you. But if Leisha comes in and she looks like me, she's talking to me in a way that I can understand, and she's assessing my risks and things like that, and she helps me understand what PrEP is and relays it to an everyday activity, then there's a good chance that I may get on it. And that's not to say, some people won't look at people that don't look like them and trust what they're saying, but the majority of the time, I'm gonna listen to somebody that look like me. Just saying, And so we need to also make sure that we have spaces available for people that's going to affect the community that look like us as well. So, Alicia, you summed it up perfectly.
That's very interesting you brought that up, because very recently I think it was yesterday or the day before, I was talking with a couple of friends of mine on FaceTime, and we were talking about, one of my friends mentioned the PrEP commercials, and she saw the one for Discovery, and she said, I haven't, she was like, this is the first time I've seen this commercial. I can't believe there's so many Black people in this commercial. I was like, well, they're trying to engage more people of color, and taking more Medicaid, like taking PrEP and being educated about it. And then she asked me, what was it? What is Discovery? And I said, the thing I'm always telling y'all, talking to you about PrEP. There's a new medication now called Discovery that also works for prevention as well. Oh, she was like, "Oh, okay, well that's great. So is it better than PrEP? Because I know that there's some, issues with PrEP and some side effects and stuff." So of course I had to go into the whole thing. The side effects are pretty much minimal. Most people don't have that many side effects. But then I had to tell her, well, Discovery isn't indicated for people that were assigned female at birth. I was like, that's the one thing about that. Yes, there are some pros and cons about Discovery. It is, less aggressive. What I've heard is that it's less aggressive on the system, but at the same time, it's not indicated for women. So that kind of led me to my next question/statement, which Kierra kind of brought in, which is representation. We need more representation of Black women in general, when it comes to PrEP. And you mentioned earlier about the research when it comes to PrEP. There's not a lot of women, especially Black women, involved in the research behind PrEP. And so what the next question is to feed into that are, what are some resources? I know both of you are very active in lots of circles, and lots of people and lots of things. What are some resources or some interventions or some strategies that you all have seen where it incorporates women and Black women, and kind of will help our providers on the call today engage Black women?
Well, I do see one of my good friends, Mata, from my brother's keeper in Mississippi, and she says that they are currently doing research. And so, Mata, it might be helpful if you would put your email or my brother's keeper's website in the chat so that people can become more informed about that, about what you guys are doing. But Shayla, this is another one of those questions that um, hits right at home, as we're talking about representation. And I would say, before we even talk about Black women being represented in research and trials, let's take it a step back and look at the need for Black women to be the principal investigators, and lead in research and clinical trials, because it truly does have a greater impact. I also see Dazon, who has joined us, and she is saying changing the conversation from risk to sexual wellness. So we talked about so far today changing from high risk and low risk to just risk, and Dazon is saying let's take it a step further and changing to sexual wellness. But I will say this: personally, I have stayed away from clinical trials and vaccine trials. I'm coming up on my 30-year anniversary in HIV. I'm talking about that a lot now, and if you guys have some ideas of what I should do to commemorate that 30 years, let me know. But I did something this month that I haven't done in my 30-year career, and I'm participating in a vaccine trial for COVID. And the reason I made a decision to participate in the vaccine trial, Shayla, is the same reason you asked that question, right? And so I want to be sure that when vaccines come available, that there isn't a side effect that's going to happen to middle-aged Black women, my hair gonna automatically turn straight or something because I'm taking the vaccine, and didn't nobody know it because we weren't in the trials. And so that was a huge step for me personally. But I'm like, I can't be out here talking about, what you're not doing for us if I can't be a part of the solution. And so for me, in terms of vaccine, part of the solution for me was to be a part of the trial. And that whole thing around this conversation about medical mistrust and distrust, we don't blow it off. We got to acknowledge that it happened. It is real, but we're not going to stay there, right? We have to begin to shift the conversation to what are some of our solutions. We can own this. We can take this back. We can be empowered to have a greater impact. And I was sharing with one of my colleagues, and then I'm turning it over to Kierra, that out of this whole process of this vaccine trial, that became the most emotional for me was when I signed my consent form. And I know that seems so minor, but for me, I'm like, when I signed that consent form, I got to do what Fannie Lou Hamer couldn't do when they took her ability to be somebody's mother, right? I got to do what Henrietta Lacks couldn't do when they decided to take her cells without her consent. I gave consent that I'm going to be a part of this study, and that I'm in the driver's seat, right? I get the chance to decide what's going to happen to my body or not. And so that was so powerful for me. But in terms of research, people within our community, they got to see more of that. Right? Leisha came out the vaccine trial, girl, her hair didn't turn straight. She good. She didn't grow a third leg. She's good. But it's not enough of us that have been a part of it to be the example. And so we can change that.
I mean, I feel like it's not much more for me to say after that.
I'm going to stop going first, Kierra, because there's so much you got in you.
No, I love you, Leisha. Listen, I'm sitting here engaged. Even though I'm on the panel, I'm always in awe when you speak. So, but just to add my 2 cents to that, I wanted to talk about, like you said, Shayla, how do we engage Black women? How do we get Black women to the trials and different things like that? For me, somebody said in the chat, we have to start being more creative of how we reach out to folks. We also, like Leisha said, we have to start shifting now. Okay, we understand the medical mistrust and distrust, but now we have to start shifting focus. And somebody also said sometimes providers use that as an excuse to not even have the conversation. Well, I don't want to have the conversation because my client don't trust me anyway. Mm-hmm. We're going to move forward. We have to start having uncomfortable conversations. Even to this day, HIV and sex is still taboo. We have to start getting uncomfortable to make changes. We have to start getting out of our comfort zone to see an actual change. I know last year, when I was the minority AIDS coordinator for Leon County, I had the Sisters Organizing to Survive event, Leisha, that you were a part of. And when we got to the conversation, and there were women, moms and daughters. And when we got to the conversation about PrEP and sex, it was, it wasn't sugarcoating anything, because sometimes we need to have those conversations. And, we laughed about it, and, some point, some people were uncomfortable, but then when we looked around the room and we all saw, like, okay, all of us are a little uncomfortable, but it makes me feel at home, because not, even though I'm uncomfortable, the people around me look like me, but now at the end of this, we're going to be better informed. We're going to know how to get PrEP. We're going to know how to get PEP, so forth and so on. And so I just think about that, the conference that we had when we got to talking about sex, like it was a real conversation. It wasn't well, the data says this or the data said, no, we had a real conversation. And so we have to get uncomfortable. We definitely have to get uncomfortable. And when it comes to like health departments, and I know we talked about the disconnection between health departments and hospitals, I've personally had to help people when they're at their hospital. They're like, Kierra, they're saying they can't give me PEP. No, they can. Or Kierra, they saying they can't test me for that. Or that's something the health department does. I work for the health department. We don't test for this. They can get this at the hospital. And so there's a disconnect that somehow we have to combine with the hospitals, because I could just personally say here, the hospitals and health departments, it's a bit of a disconnect when it comes to PrEP and PEP. Another thing is, just to throw this out there, a lot of folks don't know that all 67 county health departments in Florida offer PrEP for free. Right. Folks don't know that. But on the flip side of that, there's not a lot of resources when it comes to nPEP. And hopefully I see, just as we had the big push with PrEP being into the county health department clinics, I'll hope to see that same push when it comes to PEP, because like you say, off the top of my head, I know one community-based, it's probably just one that offers PEP outside of the hospital here. And so we have to start getting connected, getting uncomfortable, being creative, creating new initiatives, and putting people like us at the forefront, making sure Black women, if it's about us, let us have a say so. If it's about us, include us. And I go back to the Descovy trials and medications and stuff, and it was like, when I found out that it really wasn't for females or women that were born female, I was like, okay, what happened? What was the disconnect? And yes, there are people that decline out of these trials and decline out of these surveys, but there are also, on the flip side of that, people that are willing to get involved. But are you reaching those folks? How are you reaching those folks? How did you recruit Black women? Did all of the Black women that work in this field, did you reach out to those people in your inner circle to say, hey, I'm not sure if you want to be involved, but do you know other folks that may want to be involved? And how can we get this message out to the community that these trials are going on so that they can have a say so in something that affects us? And so we just have to get uncomfortable. We have to start encouraging folks. We have to make sure people are in positions that look like us, that can bring change and different things like that. And also, like I say, being creative. When I started in 2017, really in this field, I shook up a lot of things. Like, a lot of things with me were very innovative, because I'm like, something that works for me may not work for the next generation after me. Yeah, I'm pretty young and try to stay hip, but my mentees under me, they're in a whole different realm. Like, even just from the music they listen to and I listen to, and how I approach my generation is not the same how I'm going to approach that generation or a generation that's older than me, And so we just have to, like I said, get uncomfortable, get creative, connect the disconnection, and we have to shift, like Leisha said, from the narrative of the mistrust and distrust. It's never going to go away. We know that. We know the history, of our ancestors in this country, and currently what's happening in this country. But how now do we shift that? How do we shift from that to get to where we need to be? And so that's just my little 2 cents that I wanted to input.
Thank you so much.
That was great 2 cents. It was more than that. It's more than that.
There's definitely a divide, because I can't get any of those TikTok dances. I tried. I just had to chalk it off to, I'm just out of that now.
My niece is trying to teach me, and I'm like, you know what? Auntie gonna sit this one out.
Right. We're gonna sit it out. So, ladies, we're coming close to the end of our discussion today. And before we get into our open Q&A, we have a few questions in a Q&A box, and I have some that I've gotten from the chat. I just have one more thing I want to ask of you both. If people could take one thing away from today, what would it be? I'm gonna let you want to go first, Kierra, because Leisha said she didn't want to go first.
Yeah, I'm gonna go first because I know Leisha gonna take us out. But I would say, as a person, I'm just going to say it from 2 points of view. As a person who may not be in this field, because I think about at a point in time when I was not even involved in this, when I was just a student at FAMU, still trying to get STI screening and things like that, I would say you have to be your own advocate. You have to speak up. Just because this person has MD, RN, whatever behind their name, MPH, does not mean they know everything. You know you better than the provider knows you, right? You know your body. You know something ain't right. You know you the best. And so we have to start making sure we advocate for ourselves. Just because this provider says, well, you need to get back on metformin for, your diabetes. And that metformin is messing you up, having all these side effects, but you're steady taking it, and there's another alternative out there. You need to say something. So I would say, as a person that's on the patient or client side, to just be your own advocate. Speak up. You know yourself the best. Now, on the flip side of that, as a provider or a public health professional, we also have to help push advocacy for our clients as well. We have to stop also knowing that we think we know everything sometimes, and also remove our biases, because even we all have biases, right? We have to start shifting from that. We have to start our clients, because we don't know everything. We have to make sure that once we get done with this conversation, ask your client, so do you understand what I said? Do you understand? Can you repeat back what I said? Do you have any questions? Versus, okay, here's this prescription, bye. Here's the health department, bye. Come back at 4 o'clock, and then we have to get away from that. And I know we're all busy, but we have to show just a little bit more compassion. We have to also push our clients to advocate for themselves, and we have to remove these biases, and we have to work together. It's not a competition. We have to work together, and I sometimes see that a lot within organizations. Oh, well, we didn't get funded for that, so we have ideas, but since you all have the money, we're not going to help you. We have to start coming together, because it's not about us at the end of the day. Yes, I get it. I understand the rift between some organizations or the hospital and the county health departments. I get it. But at the end of the day, it's not about us. It's about a whole community of folks that if we do this behind closed doors, how is this going to help the community? And so I know I said one thing, but that's just 2 points that I wanted to make. Self-advocacy for the client, and then just getting ourselves together, working together and pushing advocacy for our clients and removing biases.
Thank you.
Yeah, I mean, just very well said, Kierra. I mean, really not much to add to that. I would say that for the provider, this is an opportunity that if you got a chance to be a part of this discussion for the past hour and 15 minutes, taking this back to your clinic or your agency, your CBO, and saying, are we implementing, these things? Have we made a decision that we're having a conversation about PEP and PrEP for everybody who comes through this door? That way we're not making an assumption about who we should be having this conversation with or not. If we don't provide PEP or PrEP at our facility, do we have resource lists, contact information, relationships with organizations that do? And so instead of telling Shayla, I think Agency X provided, you know that Agency X provided. Matter of fact, I can pick up the phone because the coordinator over there is Kierra. And Kierra, will keep me up to date and informed about what their process is for women who may be coming to that facility. And in terms of the client themselves, we still have a long way to go in terms of educating our community about PEP and PrEP. And the beauty in the out of the ashes of this COVID pandemic is that we are thinking about how we interact and engage with people in a very different way. Had I known that COVID was coming, I probably would have bought stock in Zoom, because I know Zoom is just blown up over the past 12 months. I really could have been my retirement nest egg. But we are finding different ways to engage with folk. We also got to be intentional about finding influencers as well. Everybody who will have an impact, they don't always look like even the three of us. You know, we all from that Florida Department of Health sorority, and they, you know, they all doing bigger and better things. I'm so proud of them. But there are some folks that Kierra and Shayla should be training about public health and about prep, and so they too can go on, and the people in their social circle can be having conversations to help educate and empower people. And I don't know if my mom is on this webinar. She said I tell all her business. That's true, and I'm not gonna stop today. You know, she has taken her vaccine. She's gotten both her shots, and I asked her to share her story on social media. And she was reluctant at first, but I said, "You are an influencer. There are women, there are people in our rural community in Florida that are going to do it because you did it. Not what they heard Dr. Fauci say, you know, not what they read from the CDC. They saw you do it. And when it happened, she contacted me and she was like, Leisha, you know, I'm getting this something wrong with my phone. I said, what's wrong with your phone? And then it was binging, right, while she's on with me. And I'm like, oh, I said, you have Messenger. And now that bell that you hear, that's how she described it as a bell. That bell that you hear are all of these direct messages that people were sending to her about how does she feel? What made her decide to do it? You know, did she have any side effects? Where did she go to get her vaccine? I'm like, girl, now you a social media influencer. Go ahead with your bad self, you know, but that's what it took for some people. And so I'm saying we all get to leave here with a responsibility, you know, to educate folks about what we know about PEP and what we know about PrEP, so that when we're not available or when we're not present, that doesn't stop the show. People can still access those services. And when they go in like Kierra said, I'm knowledgeable, I'm empowered. I don't have to wait for them to offer, although they should, but I get to ask for myself.
Thank you both so much. So we have about 10 minutes left, and we have a couple of Q&As that I've pulled out. So we have two questions that are very similar. Um, and basically the question is, what role can LGBT oriented nonprofits that work in prevention play in promoting PrEP for Black women?
Yeah, I saw that question. I'm glad that you brought that one out, Shayla. And you know, I when we talk about Black women, we're not just talking about Black women who identify as heterosexual. We're talking about Black women across the board, you
Hmm.
know. And so using those organizations and platforms, I don't know if Dazon is still on, but Dazon uses a term that I also have taken from her, is that when we talk about Black women, we talking about Black women in all our diversity. And so whatever that is, that's you know, that's what who we're talking about. But using that platform to educate Black women about these prevention tools and strategies, and even preparing and equipping them to be mindful of the stigma that comes along with it. That's not the reason that you don't do it. I'm giving you the tools to help you overcome that. And then they'll be able to go and help educate someone else about their experience.
Thank you. Do you want to add anything, Kierra?
So I missed the first part of the question. My internet kind of went out a little bit, so I caught the very end. Can you repeat the question?
Yes, it says, what role can LGBT-oriented nonprofits that work in prevention play in promoting PrEP for Black women?
Oh, okay. Thank you. Yeah. Well, pretty much exactly what Leisha said. When we talk about Black women, we're talking about all Black women, and so I think collaboration is key. And sometimes when it comes to LGBT Q plus orgs, I know that their priority population is people in that community, but also making sure that you're welcoming of people that may not identify in that community. And I'm not saying that that's the case or whatever, but making sure that we have a welcoming environment for those women who may feel comfortable going to that site versus the health department. I can just personal experience, just when I go to the club and stuff, like when I went pre-COVID, believe it or not, I would feel more comfortable in the gay clubs versus the straight clubs, because I felt, more at ease and more accepted, I guess. And so just making sure that atmosphere is the same when it comes to the clinic site, if that is your priority. Because sometimes, like I said, everybody don't come to the health department. Everybody can go to the hospital. So you that yes, this is our priority population, or this is the population that we serve the most, but we're welcoming of all people and making sure that there are collaborative efforts with other organizations that may serve people outside of your priority population. So
Yes. So we're coming, I think probably have time for maybe one or two more questions. So another question is, what happens if you decide you want to come off PrEP? What is to be the expected reaction to the client?
Well, I think that, just like we assess, I'm modeling what Dazon Dixon Diallo shared with us to model sexual wellness. Just like you did an assessment for sexual wellness to go on, doing an assessment of sexual wellness to go off, and then having that conversation with your doctor that I have situations in my life that have changed. I had a partner. I may no longer have that partner anymore. I may be taking a sabbatical from sexual activity, and I pray that never happens in my lifetime. But if circumstances change and I'm and I'm not sexually active, then that may be a determining factor. Okay, well then PrEP I may not be part of the prevention strategy for this time. And that's the beauty of this whole process about choice, right? I'm able to determine what is best for me at this time. And so I may need to reevaluate my prevention strategy and determine I may need a little bit more, I may need a little bit less, but that's your choice. But women can't do that if they are not educated and informed about what their choices are. And that's a part of that takeaway for me as well, Shayla. We have to look at campaigns to raise awareness for women. Our partners that have deep pockets, like the pharmaceutical companies, it's great what we've seen you do with campaigns for other populations, but there needs to be campaigns for women, specifically for women in all of our diversity, but there needs to be campaigns for women that I get to see when I turn on networks like BET or ABC, just like we've seen for other populations. So that's my charge to the pharmaceutical companies. And then my charge to states and local jurisdictions, which I'm going to be talking about for the entire month of March, is have a specific plan for women as a part of your ending the HIV epidemic. We get 2 or 3 sentences and a 90-page statewide or jurisdictional plans. And we don't get to the end of the epidemic for us without there being some priority in those jurisdictions for women.
I definitely agree. And I just want somebody commented and said, for referring back to the previous questions about the LGBTQ plus sites, is to just make sure, because some of them are grant funded, but making sure when they're writing their grants to be inclusive, include inclusive language and things like that. And then we're just referring back to the question about, when someone decides they want to come off, having those same conversations, the same enthusiasm you gave this client, putting them on, give them the same enthusiasm and support, letting them while they're coming off of it, and letting them know that, hey, there comes a time down the they need to be back on it. Come back on and see me. We're going to go back through the same process and reevaluate and adjust. So and you need to keep that same energy, as folks would say.
Right. Well, ladies, I am so thankful for today. It has been a wonderful discussion. As you can see from our chat, we've definitely created the opportunity to discuss and to grow and to improve how we're engaging Black women. So I want to thank both of you so much today for joining. I want to thank everyone who came as a participant. I will be sending out an evaluation in a little bit. So if you could just go ahead and fill out that evaluation, let us know how we did so that we can continue to improve and make things better. And I want to thank everyone again. Thank you, Leisha. Thank you, thank you, thank you. Thank you, Kierra. Thank y'all so much. I'll be at the next BTAM meeting. I'll be there. And I want to wish everyone a happy Friday Eve. Thank y'all so much.